Hi, everyone. We'll get started in just a moment. Okay, great. Welcome, everyone. Thanks for joining us today for this webinar in the Pathways to Prevention series. Today's webinar is titled Substance Use Among Pregnant and Parenting People, Research and Interventions to Promote Wellbeing with Anna Austin. And before I introduce her, I'll give a little background about the series. It is a partnership between the Injury and Violence Prevention Center and the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health and Director of Outreach with the Injury Center. I want to start by acknowledging that both of our sponsoring organizations are based at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. And as we gather, we honor and acknowledge that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. And we acknowledge the 48 contemporary tribal nations that are historically tied to the lands that comprise what we now call Colorado. This webinar series, Pathways to Prevention, is designed to connect prevention workers with the latest science on protecting children and ensuring well-being of families. We offer these free monthly webinars designed for those working in public health organizations, social services, child welfare, and the nonprofit sector. And during these sessions, you'll hear from researchers working on a variety of different topics in the primary prevention of child abuse and neglect, as well as adverse childhood experiences. We hold them on the 3rd Wednesday of the month at this time, and we do record them. So the recording for today will be available and will be emailed out to everyone who registered for the session. So if you ever miss a session, you can always watch the recording at a time that's convenient for you. They're posted on our website as well. And I wanted to let you know that our next webinar in December will be on December 15th, and it's titled Building a Trauma-Informed Community, the San Antonio Experience. And we'll be hearing from Colleen Bridger, who was formerly the Assistant City Manager and Interim Health Director for the City of San Antonio, and is now the founder and CEO of Colleen Bridger Consulting. And we have other sessions scheduled through next February, so you can check those out. I'll drop a link in the chat where you can register for upcoming sessions. I also wanted to let you know that at the end of the webinar, you'll be sent to a brief feedback survey, and I hope you'll take a few minutes to share your feedback on today's webinar and any ideas you have for future sessions. Right. So now I'd like to introduce today's speaker. We're very happy to be welcoming Anna Austin. Dr. Austin is an assistant professor in the Department of Maternal and Child Health and core faculty at the UNC Injury Prevention Research Center. She's trained in epidemiology and maternal and child health with a focus on injury and violence prevention among children and families. Her current research centers on the primary prevention of adverse childhood experiences, specifically child abuse and neglect, substance use among pregnant and parenting people, and population level strategies, including those that address material hardships to prevent injury and violence and promote child and family well-being. We're very happy to have you here today, and I'm going to turn things over to Dr. Austin. And for everyone in the audience, if you have questions while Dr. Austin is presenting, please feel free to put those in the Q&A box, and we'll have time at the end for questions. All right, welcome.
Great. Thank you, Sarah, so much for that introduction. And thank you all so much for joining today. Today, we'll be discussing substance use among pregnant and parenting people with a specific focus on existing research and interventions to promote well-being. So what we'll talk about today really just begins to scratch the surface of everything that's relevant to this really important topic. So to give you an idea of what we'll talk about today, we'll start off by reviewing data on the epidemiology of substance use in pregnancy overall, and with a specific focus on opioid use disorders, and related outcomes. We'll then move into discussing various state policies specific to substance use in pregnancy and existing evidence on their impact on pregnant and postpartum people. We'll then move into talking about the provisions in the Child Abuse Prevention and Treatment Act specific to infant prenatal substance exposure. And I'll share some results from a quality improvement project we conducted in North Carolina on what's called our North Carolina Plan of Safe Care. And then we'll close out by discussing parental substance use as it relates to child safety and well-being. And we'll specifically take a look at some data regarding child welfare involvement related to parental substance use. Okay, so first taking a look at some epidemiology and trends in substance use in pregnancy. These data are from the National Survey on Drug Use and Health, showing the percent of pregnant people ages 15 to 44 years who reported use of alcohol, tobacco products, and illicit drugs in the past month from 2015 to 2020. So what we see here, we can see there are some fluctuations over time, with the highest percent of pregnant people reporting past month use of each substance category in 2017, followed by some declines in 2018 and 2019. In 2020, we see a small increase in the percent of pregnant people who reported past month use of alcohol to nearly 11%, and a larger increase in the percent who reported past month use of illicit drugs, up to about 8.3%. So I'll note here this illicit drug category. It includes multiple different substances, marijuana, cocaine, heroin, other illicit drugs, as well as misuse of prescription medications. And so we take a look at this category further. We see that the majority of reported illicit drug use in the past month among pregnant people is marijuana. And we see here a substantial increase in past month marijuana use observed in 2020, up to about 8% of pregnant people. So overall for 2020, the most recent year of data available, about 1 in 5 pregnant people reported past month use of either alcohol, tobacco, or illicit drugs. And I'll note here too, these 2020 data were just released, and the increases we see in these 2020 data for some substance use categories may reflect changes in substance use behaviors due to the many stressors of the COVID-19 pandemic, but they also may reflect changes in the mode of survey administration due to the COVID-19 pandemic. So they moved from in-person surveys to online surveys during that time. So looking at a different population representative data source, the Pregnancy Risk Assessment Monitoring System Survey, or PRAMS. So 19 states included a question about prenatal substance use on their PRAMS survey for 1 or more years from 2016 to 2019. And based on our analysis of these data, nearly 9% of PRAMS participants in these states reported use of prescription opioids, marijuana, medication for opioid use disorder, amphetamines, heroin, cocaine, and so on at any point during pregnancy. And what we see here is the most commonly reported substance use categories were prescription opioids at about 6% and marijuana at about 5%. So the data on the prior slide, that was based on pregnant people's self-report of substance use. We look at data on documented diagnoses here for opioid use disorder in pregnancy. These data show rates of diagnosed opioid use disorder per 1,000 hospital deliveries in the US. And we see that these rates more than quadrupled from 1999 to 2014. So here I do want to note that these increasing trends might reflect both true increases in rates of opioid use disorder in pregnancy, as well as changes over time in screening and diagnosis for opioid use disorder. So in the context of our ongoing overdose crisis, we may be on higher alert for potential substance use disorders, both overall and in pregnancy. So we might be conducting more screening and doing a better job of identifying, diagnosing, and documenting opioid use disorders. So tangled up in these increasing trends might be both true increases and increases due to improved ascertainment. A lot of attention has been focused on opioid use, again, overall, and specifically in pregnancy, given the contribution of opioids to the current overdose crisis. However, there have also been changes in patterns of other types of substance use in pregnancy. So this graph shows data for hospital deliveries with identified amphetamine or opioid use. So we see here from 2004 to 2015, there were increases in the number of amphetamine and opioid-related deliveries per 1,000 hospital deliveries overall, as shown in the dashed lines, and particularly large increases in these rates in rural counties, as shown in those solid lines. So really importantly, these data also showed significant polysubstance use, with nearly half of opioid and amphetamine-related deliveries having comorbid tobacco use. and also really notable percentages of comorbid use of marijuana, cocaine, alcohol, and sedatives among these deliveries, really highlighting the importance of considering polysubstance use. So now that I just noted the importance of considering polysubstance use, I'm going to switch back to focusing on opioids specifically. The medication for opioid use disorder, or MOUD, this is the recommended evidence-based treatment for opioid use disorders in pregnancy. MOUD is a highly effective treatment that is consistently shown to decrease the risk of opioid-related morbidity and mortality, both overall and specifically in pregnancy. So MOUD in pregnancy is typically treatment with either methadone or buprenorphine, which are medications that act on the same receptors in the brain as other opioids, but more slowly or less strongly, so that they prevent cravings and withdrawal symptoms without producing the same euphoric effects as other opioids. Multiple studies show benefits of MOUD for pregnant people's outcomes as well as infant outcomes. So compared to continued opioid use or detoxification, MOUD in pregnancy is associated with a reduced risk of preterm birth and low birth weight among infants, improved attendance at prenatal care, and a reduced risk of overdose in pregnancy and postpartum. So to further highlight some of these benefits of MOUD in pregnancy for both the pregnant persons and infant outcomes, this recent study used data from Pennsylvania Medicaid for pregnant people with diagnosed opioid use disorders and examined the association of the duration of MOUD in pregnancy with a number of different outcomes, showing that as the duration of MOUD in pregnancy increased, the risk for overdose in pregnancy and postpartum decreased, the likelihood of continuing MOUD postpartum increased, and this is important because some other studies suggest that the 7 to 12 months postpartum are the highest risk period for overdose among pregnant people with an opioid use disorder. In addition, the risk of preterm birth and low birth weight among infants also decreased. This really highlights the importance of pregnant populations receiving MOUD as early as possible in pregnancy and continuing MOUD throughout pregnancy. And so for us, this really shows us the importance of creating non-stigmatizing, supportive, recovery-oriented environments for pregnant people with opioid use disorders. And we'll talk some more in a few slides about that. So in terms of the availability of substance use disorder treatment for pregnant and postpartum populations, a recent study analyzed data from the National Survey of Substance Abuse Treatment Facilities for 2018. And this is a survey of public and private treatment facilities in the US. And so here they identified the percent of facilities that offered a specialized program for pregnant and postpartum people. And then they looked at the additional services that facilities with these specialized programs offered. So these data showed that for 2018, less than 1 in 4 substance use disorder treatment facilities had a specialized program for pregnant and postpartum people. And there was considerable variability in the availability of these specialized programs across states, with lower availability in the Midwest and South, as shown here on this map in darker shades of green. With respect to the additional services offered by facilities with a specialized program, less than half offered buprenorphine and only about a fourth offered methadone. Only about, well, less than 1 in 5 offered childcare. And this is really important because a lack of childcare may be a particular barrier to pregnant and postpartum people engaging in substance use disorder treatment. In addition, about half to 70% of these facilities offered intimate partner violence services, housing assistance, or employment assistance, which is really important because substance use disorders, substance use in pregnancy, often occurs in the context of co-occurring health, social, and economic challenges, such as comorbid mental health conditions, material hardships like food insecurity, housing instability, transportation difficulties, employment challenges, and so on. So one thing to note here is that these additional services, which are really important, these were more common in facilities that had a specialized program for pregnant and postpartum people compared to facilities that did not have a specialized program. And this is important because the majority of facilities, 77%, did not have a specialized program, sort of suggesting important gaps in services that may help to facilitate treatment and recovery among pregnant and postpartum people. And there is some other research suggesting that programs that offer comprehensive integrated approaches to treatment that combine clinical services with social services such as intimate partner violence, housing and employment services, that these are really effective in improving overall outcomes. So turning to think about infant outcomes in the context of opioid use in pregnancy, neonatal opioid withdrawal syndrome, or NOWS, is a drug withdrawal syndrome in newborns that occurs following abrupt discontinuation of in utero exposure to opioids. So NOWS can result following in utero exposure to prescription opioids, MOUD, or illicit opioids like heroin. NOWS is diagnosed based on signs and symptoms observed after delivery, and these symptoms can include minor behavioral problems like feeding difficulties and high-pitched crying, and less often major problems like seizures and failure to thrive. Notably, these symptoms vary widely in terms of the onset, duration, and severity, both between infants and within the same infant over time. Really importantly, NOWS is both a treatable and expected condition following prenatal opioid exposure, including exposure to prescription opioids, MOUD, and illicit opioids. There are both pharmacological and non-pharmacological treatments available for NOWS. Non-pharmacological treatments are increasingly used. So these treatments, like the Eat, Sleep, Console method, that really focus on caregiver-infant bonding through rooming in, supports for breastfeeding or chest feeding, providing low stimulation environments to promote undisturbed sleep for infants. These have really been shown to decrease the severity of symptoms of NOWS, as well as to reduce the length of hospital stay and overall associated healthcare costs. So as with increases in opioid use disorder diagnoses in pregnancy, if we look at national hospital discharge data, we see that from 2004 to 2014, the number of diagnoses for NOWS per 1,000 live births increased substantially, as shown in the solid line in the middle. We also see that there were higher rates and larger increases in these rates among deliveries financed by Medicaid compared to deliveries covered by private insurance. So here, both a truly higher rate of NOWS among deliveries covered by Medicaid, as well as differential screening, surveillance, and diagnosis among the Medicaid compared to the privately insured population, may contribute to this difference we see here. So some of this difference may reflect which populations are targeted for observation, screening, and a subsequent diagnosis of NOWS. And so I think some of this can lead to a little bit of circular logic. So if we see higher rates of NOWS in the Medicaid population, we may be more likely to monitor for the signs and symptoms of NOWS in the Medicaid population, leading to more diagnoses of NOWS in the Medicaid population and confirming our assumptions. So just, really encouraging us to think carefully about what may be contributing to these differences and increasing trends. So in North Carolina, we conducted a study to examine use of MOUD and other prescription opioids in pregnancy among mothers of infants diagnosed with NOWS. And the goal of the study was to inform appropriate pre- and postnatal intervention and to hopefully address some of the stigma associated with NOWS diagnoses by highlighting the extent to which some of these cases may be related to use of evidence-based treatment or opioids as prescribed by a healthcare provider in pregnancy. So what we found was that in the graph on the left, among mothers of infants diagnosed with NOWS in the North Carolina Medicaid population from 2016 to 2018, the percent with claims for MOUD in pregnancy increased over time, which indicates increased receipt of evidence-based treatment. Over the entire study period, we found that 60% of mothers of infants diagnosed with NOWS had a claim for MOUD or another prescription opioid in pregnancy, with nearly half having a claim for MOUD and about 1 in 5 having a claim for another prescription opioid, which really underscores the extent to which cases of NOWS may be related to medically necessary opioid use in pregnancy. In some subgroup analyses, we found that younger women and Black non-Hispanic women were underrepresented among those with claims for MOUD in pregnancy, indicating that there is still a lot of work to do to improve equity and access to evidence-based treatment for opioid use disorders in pregnancy. And this does line with a large body of research showing racial inequities in receipt of MOUD, both overall and specifically in pregnancy. Okay, so states have taken a variety of approaches to addressing substance use in pregnancy, including implementing different policies and programs. So here we will discuss two specific policies, child abuse and mandated reporting policies. Currently, 23 states and DC have expanded their civil child welfare definitions to include prenatal substance exposure, so that prenatal substance exposure can provide grounds for terminating parental rights due to abuse or neglect. In addition, in their child abuse and neglect reporting laws, 26 states and DC require healthcare providers to report infants with suspected or confirmed substance exposure to Child Protective Services. And really the primary argument in support of these policies is that the threat of punishment will deter pregnant people from using substances. However, leading medical and public health organizations such as the American Public Health Association, the American Medical Association, many others, they recommend against these types of policies, saying that they may undermine healthy outcomes by discouraging pregnant people who use substances from engaging in prenatal care and substance use disorder treatment in order to avoid punitive responses to their substance use. So several qualitative studies have gathered information from pregnant and postpartum people with substance use on their experiences in healthcare encounters and their perspectives on these policies. This research shows that pregnant and postpartum people with substance use experience substantial stigma and judgment in healthcare encounters. And this can be a barrier to forming positive relationships with healthcare providers and to facilitating continued engagement in care. Many also report that when providers are empathetic, clearly communicate, and include them as a key partner in decision-making, they feel more supported and are more likely to want to continue returning for care. Several studies also indicate that pregnant and postpartum people with substance use will delay or avoid prenatal care and substance use disorder treatment, or avoid disclosing their substance use to their healthcare provider out of fears of providers as mandated reporters and the potential for loss of infant custody. So this research also indicates that these fears are amplified in the context of child abuse and mandated reporting policies. And overall, from this body of literature, it indicates that child abuse and mandating reporting policies are perceived both by pregnant people and healthcare providers as punitive. A growing number of studies have examined the association of child abuse and mandated reporting policies with substance use disorder treatment and healthcare use. These studies show that these policies are associated with decreased admissions to substance use disorder treatment among pregnant people, decreased receipt of MOUD among pregnant people with opioid use disorders. In one study, while they found that Medicaid expansion was associated with increased receipt of MOUD among pregnant people with opioid use disorder, this only held in states that did not have a child abuse policy, suggesting that child abuse policies may prevent the benefits of other policies like Medicaid expansion from being fully realized. And in our own research, we found that these policies were associated with later initiation of prenatal care, a lower likelihood of adequate prenatal care, and a lower likelihood of a postpartum visit among those with substance use in pregnancy. So in addition to deterring engagement in prenatal care and substance use disorder treatment, these policies have the potential for inequitable impacts and to exacerbate existing inequities, and specifically those related to structural racism. So if we consider one of Kentucky's policies, which states that a petition to terminate parental rights cannot be filed for a pregnant person who used non-prescribed controlled substances in pregnancy if that person enrolls in and maintains substantial compliance with substance use disorder treatment and prenatal care. So in Kentucky, prenatal substance use can be grounds for termination of parental rights, but not if the pregnant person enrolls in and maintains compliance with substance use disorder treatment and prenatal care. What this policy does not do is it does not recognize the many barriers and challenges that pregnant people with substance use face in enrolling in and continuing care and treatment. So as we mentioned before, substance use in pregnancy often occurs in the context of co-occurring health, social, and economic challenges, including mental health comorbidities, housing instability, employment difficulties, lack of transportation, many others. And this policy doesn't provide any supports related to these additional challenges that may be barriers to engaging in care. In addition, this policy doesn't recognize that certain populations have reduced access to healthcare services, and thus could be seen as punishment for the inaccessibility of healthcare. So for example, prior research shows that there is a lower availability of MOUD and other substance use disorder treatment in rural areas. In addition, multiple studies show that Black and Hispanic pregnant people, again, are less likely to receive MOUD and other substance use disorder treatment compared to white pregnant people. So with this treatment requirement in this policy, with no additional support or acknowledgement that some populations have reduced access to treatment, it may have the potential to exacerbate existing underlying inequity. Okay, so turning to talk about plans of safe care, under the Child Abuse Prevention and Treatment Act, or CAPTA, states are required to create and implement policies and procedures to address the needs of infants identified as substance affected. And this includes the requirement for the development of what are called plans of safe care for substance affected infants. CAPTA is the federal legislation that provides funding to state child protective services agencies, or CPS, to receive and respond to reports of suspected abuse and neglect. And the requirements for plans of safe care are included in the CAPTA legislation. So to walk you through a brief timeline of CAPTA, CAPTA was enacted in 1974. In 2003, CAPTA was reauthorized, and this was the first time CAPTA included provisions specific to infant prenatal substance exposure. This reauthorization included new provisions requiring states to create and implement, again, policies and procedures to address the needs of infants identified as affected by exposure to illegal substances through the development of a plan of safe care for substance affected infants. And it also includes a requirement for healthcare providers to notify CPS of these cases. In 2010, CAPTA was reauthorized, and these provisions were revised to include a requirement that states also address the needs of infants affected by fetal alcohol spectrum disorder, in addition to infants affected by exposure to illegal substances. So these initial provisions, they weren't accompanied by additional funding and really did not receive much attention until the 2016 Comprehensive Addiction and Recovery Act, or CARA. So in 2016, CARA amended CAPTA, and it clarified that plans of safe care should address the needs of both substance-affected infants and their caregivers. And it further expanded these provisions to include infants affected by prenatal exposure to prescription drugs like opioids by removing the word illegal. Earlier this year, 2021 reauthorization of CAPTA was introduced. It includes some additional revisions to the language included in these provisions, and it includes a new mandate for states to create separate systems for notifications for substance-affected infants to CPS and for reports for suspected maltreatment to CPS, and we'll discuss that further on the next slide. So this is some of the language from the 2016 CARA amendments to CAPTA. Again, these amendments specify that states are to develop policies and procedures for addressing the needs of infants identified as affected by, with the word illegal removed, substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder. If passed, the 2021 reauthorization would modify this language describing covered infants to those affected by substance use disorder, including alcohol use disorder. And so this sort of moves us away from focusing on infant diagnoses like withdrawal symptoms to focusing on caregiver diagnoses. In addition, these provisions don't define what affected by prenatal substance exposure means. States have flexibility to define what it means for an infant to be affected by prenatal substance exposure, and state definitions vary in detail and complexity. And so this is important because it has implications for which infants and families receive plans of safe care and potentially come to the attention of CPS. So you can see here the CARA amendments to CAPTA also specify that a healthcare provider is to notify CPS of all infants they identify as substance affected. And this 2021 reauthorization, it would mandate the creation of separate systems for notifications for substance affected infants and reports for suspected maltreatment. So in these provisions specific to substance affected infants, use of the word notify is intentional. In other places in the CAPTA legislation, the words report or refer are used. Use of the word notify here was to make it clear that these provisions do not expand the federal definition of what constitutes child abuse and neglect to include prenatal substance exposure. So here, a notification for a substance affected infant does not necessarily constitute maltreatment or mean that maltreatment is suspected. CPS staff are to assess the level of risk to the infant and determine whether CPS involvement and a further maltreatment assessment are needed. However, many states, including North Carolina, do not have a notification process that is separate from the process for reporting suspected maltreatment. So a notification essentially functions like a report for suspected maltreatment. This mandate in the 2021 reauthorization is intended to make this distinction between notifications for substance-affected infants and reporting for suspected maltreatment clear. And there are states that already do have two separate pathways, one for notifications for substance-affected infants when infant safety is not a concern, and another for making a report to CPS for a substance-affected infant when there are concerns for infant safety and there's concerns for potential risk for maltreatment. So again, looking at this language, as specified in the CARA amendments to CAPTA, these policies and procedures are to include the development of a plan of safe care that addresses the health and treatment needs of both the infant and the caregiver. The 2021 reauthorization would change the term plan of safe care to family care plan to move away from the assumption that all substance-affected infants are not necessarily safe in their homes. And these 2021 reauthorization really emphasizes that these plans should be multidisciplinary and accomplished through coordinated service delivery. So in response to those 2016 CARA amendments to CAPTA, North Carolina began implementing the North Carolina Plan of Safe Care in August 2017. So to walk you through how these provisions work in one state. So in North Carolina, healthcare providers involved in the delivery and care of infants are required to notify CPS of all infants they identify as substance affected. At the time the healthcare provider makes the call to CPS about the substance affected infant, the child welfare social worker completes what's called the Plan of Safe Care at the time that call is received. This Plan of Safe Care is a form that indicates the types of health and social services linkages that may benefit both the infant and their caregivers. This Plan of Safe Care form then functions as a referral to a third agency, a care coordination agency located in local health departments in North Carolina called Care Management for At-Risk Infants, or CMARC. Care managers at CMARC then engage with families to further identify infant and caregiver needs and to connect them with community-based services and resources. And so notably here, family engagement with CMARC and the services offered is voluntary. And then back at child welfare, after CPS social workers have made the referral to CMARC, these social workers then determine whether to screen in or screen out the infant for a further maltreatment assessment. We conducted a quality improvement project in North Carolina to examine implementation of the North Carolina Plan of Safe Care in Wake County, which is one of our largest counties. Through in-depth interviews with stakeholders from the agencies involved in program delivery, including a variety of healthcare providers, CPS social workers, and care managers at CMARC. We identified a number of key themes from these interviews. So first, stakeholders consistently expressed concerns about the requirement for a CPS notification for all substance-affected infants, particularly for infants affected by prenatal exposure to marijuana or MOUD, in which there were no additional safety or well-being concerns. So we learned from stakeholders if, for example, a caregiver used MOUD in pregnancy, again, this evidence-based treatment for an opioid use disorder in pregnancy, or only used marijuana during the first trimester of pregnancy, but not later in pregnancy. If the infant's urine or meconium tests positive, or the infant shows withdrawal symptoms, the infant and family will still receive a notification to CPS. So here they really emphasize the importance of balancing the need to ensure infant safety and well-being against the risk of potentially stigmatizing families and overburdening CPS and CMARC with a number of cases that don't have additional safety and well-being concerns. Stakeholders also indicated that the form used to refer infants and families from CPS to CMARC, or the plan of safe care form, is vague, and it doesn't prompt inclusion of specific information about the infant, their caregivers, and their overall surrounding context. And they suggested collaborative efforts across stakeholder groups to redesign the form would be helpful. Similarly, stakeholders indicated that there are substantial gaps in information sharing between agencies due to confusion regarding what information can and should be shared. So they stated that they need more structured guidance from state agencies regarding expectations for coordination and information sharing in order to improve the efficiency and effectiveness of the program. And then last, stakeholders expressed that there are challenges related to engaging families in CMARC and the services offered by CMARC, given that these services are voluntary. The CMARC care managers shared that because the referral to their care coordination services comes from CPS, many families associate CMARC with CPS and view CMARC as a watchdog for CPS. And in other states, this does work differently. The referral to care coordination comes directly from the healthcare provider rather than CPS. So as part of this project, we also examined data for all infants with a plan of safe care notification to Wake County CPS from January 2018 to October 2019. In total, 91% of infants with a plan of safe care notification were screened in for maltreatment assessment. And among infants screened in for a maltreatment assessment, the majority, 70%, were exposed to marijuana only. So in North Carolina, for infants screened in for a maltreatment assessment, CPS provides service recommendations. And there are a couple of different service recommendations that can be made, but here I'll focus on just two for the sake of simplicity. So the first service recommendation is a determination of services not recommended, which indicates that infant safety is not a concern and the family is not in need of other non-safety services, so infant well-being is also not a concern. And the second recommendation is a determination of in need of services, which indicates that there are safety issues and the future risk for harm to the infant is great enough to require the family to engage in involuntary home services. We saw some notable differences in service recommendations by substance exposure type. More than half of cases of marijuana exposure were found to not have safety or well-being concerns, and so a determination of services not recommended was made. And this is really notable given that 70% of all plan of safe care notifications during this time period were for marijuana exposure. In addition, we also saw that more than half of cases of cocaine, opioid, or polysubstance exposure, which again did represent a smaller percentage of plan of safe care notifications, these were found to be in need of services, meaning that infant safety was a concern and that the family was provided involuntary in-home services. Okay, so moving into sort of the final section of information. In the context of the current overdose crisis, there have been a lot of discussions about child safety and well-being in the context of parental substance use. And there have been specific concerns that increased opioid use overall and among parents specifically is driving record numbers of children into CPS and the foster care. Okay, so this graph, it shows foster care entries in the US from 2000 to 2017. So what we see here in the orange line at the top is that between 2012 and 2017, the number of foster care entries in the US increased after more than a decade of decline. We also see that the number of foster care entries attributable to parental substance use increased from 2000 to 2017, as shown in the dark blue line at the bottom. And the number of foster care entries due to other reasons decreased, as shown in that bright blue line. So this may suggest that increased parental substance use, increased substance use in the population is contributing to increases in foster care caseloads. And so notably, these trends in foster care entries also coincide with increases in overdose deaths during this time period in the US. However, there are other potential explanations for increases in foster care entries and increases in entries related to parental substance use, including greater attention to parental substance use, both by mandated reporters and CPS agencies, as well as altered approaches to data collection and reporting of parental substance use by CPS agencies. So some prior research indicates that there are large inconsistencies both within and between state CPS agencies with respect to documenting the role of parental substance use in foster care entries. So while some states may underreport the role of parental substance use in CPS cases and in foster care entries, data collection improvements in other states in recent years may have resulted in some artificial increases. So there are a variety of different pathways by which increases in substance use overall in the population and specifically among parents may contribute to larger CPS caseloads. So first, there's a direct pathway. So it may be that increased parental substance use in and of itself increases the risk for child harm. There may also be some indirect pathways. So in the context of increased parental substance use, the risk for child harm may be increased due, again, to some of the health, social, and economic challenges that often co-occur in the context of substance use, again, such as mental health conditions, material hardships, lack of community and social support. An additional pathway by which increases in parental substance use may contribute to greater CPS caseloads is related to the role, again, of mandated reporters, who in the context of increased attention to substance use, increasing numbers of overdose deaths, a lot of different media headlines, many policy changes, they may be sensitized to the potential risks of parental substance use and may be more likely to make a report to CPS when parental substance use is present. And then the last pathway I have here is that the CPS system itself may respond differently to parental substance use based on the degree of substance use and overdose deaths in the population overall. So like mandated reporters, the CPS system may also be sensitized to the potential risk of parental substance use and may respond differently. Okay, so if parental substance use is contributing to a greater number of children coming to the attention of CPS and increases in foster care entries, what are some policies that we can put into place to support parents with substance use disorders to hopefully prevent the need for CPS involvement and prevent child removal from the home? So this study examined whether policies that should support those with substance use disorders, first, Medicaid expansion, so supporting those with substance use disorders through increased healthcare coverage and increased healthcare access. And second, state coverage of methadone as a treatment for opioid use disorder in their Medicaid programs. So providing coverage for this evidence-based treatment for opioid use disorder. The study examined whether those two policies were associated with different trends in first-time foster care entries due to parental substance use. Here, figure A is showing among states that did not expand Medicaid, and figure B shows results among states that did expand Medicaid. The blue line is showing foster care entries in states where methadone was covered by Medicaid, and the red line shows foster care entries in states that did not cover methadone in their Medicaid program. So we can see here in both, coverage of methadone in Medicaid was associated with a lower increase in foster care entries due to parental substance use, particularly in states that also expanded Medicaid. In addition, we see that this increase in foster care entries due to parental substance use was largest in states that expanded Medicaid but did not provide coverage of methadone. So Medicaid expansion can improve access to MOUD for those who are eligible, But if not all states are also providing coverage for methadone as an evidence-based treatment for an opioid use disorder, this may be an important driver of actual treatment success in these states. Okay, so just to briefly summarize all of the material that we've gone through today, we see increases in documented substance use and substance use disorders in pregnancy. Existing evidence indicates that child abuse and mandated reporting policies specific to substance use in pregnancy are associated with reductions in receipt of essential care and treatment. Earlier this year, the 2021 CAPTA reauthorization was released. And as part of this 2021 reauthorization and specific to infants with prenatal substance exposure, there would be a requirement for states to develop and implement new processes related to plans of safe care, or what may now be called family care plans. And sort of the overall stated purpose of these revisions has been to support the health and well-being of infants and their mothers rather than to penalize the family. And last, there are multiple different pathways by which parental substance use, increases in substance use in the overall population may impact CPS caseloads. Right, so thank you again all for joining today. Sarah will facilitate some question and answer after this. My email is also here. I am happy to talk further, answer any additional questions. I'm also happy to share any of the papers, any of the citations that were throughout these slides. If you can't get access to them, I'm happy to share that. So thank you again.
Great. Thank you, Anna, for a very interesting presentation. I really appreciate the way you wove in research and data and policy issues. It's a very complex topic, and I appreciated the overview that you gave of this. I'll share a couple questions that are coming in, and I'll encourage others listening, if you do have questions, you can put those in the Q&A. We got a question. Do we know how many cases with NOWs have child protective services involved after birth? Is there data on that?
Yeah, that's a really good question. I don't know, and I imagine that it varies by state. So as I noted a couple of slides earlier when talking about plans of safe care, states have the flexibility to define what it means for an infant to be affected by prenatal substance exposure. And so with our definition in North Carolina, the way that's been operationalized, infants diagnosed with NOWs would come to the attention of CPS. I don't know, these definitions vary pretty widely from state to state. So other states may have different policies. Other states may also sort of have these separate pathways for notifications for substance affected infants when there are no safety concerns, and when there are safety concerns set up so that, not all NOWs infants necessarily have CPS involvement following birth. There is some additional research from other states showing that, compared to infants without prenatal substance exposure, those with NOWs are more likely to have CPS involvement following birth, which isn't surprising.
Okay, thank you. And so speaking of state variability, which seems to be a really important theme here, we got another question about states that have legalized marijuana use. And whether the notification recommendations differ, and I'm sure you don't know for every state, but do you know of any work in that area around like how marijuana legalization might be impacting?
That's a really good question. And I'm sorry to say that I don't know, but I can look into it and follow up with Sarah afterwards. I don't know sort of how, this legislation specific to infant prenatal substance exposure, these plans of safe care, differs by whether states have legalized marijuana or not. I imagine, there may be some differences in, again, how that definition of substance affected infants looks in states that have legalized marijuana. In North Carolina, we haven't legalized marijuana. And so, infants with prenatal marijuana exposure get included in that definition of substance affected infants. They get a notification to CPS. But I think that is a great question and something that would be really interesting to look into further.
Great. Thank you. I wonder about COVID, of course, and what intervention during COVID has looked like. I know you mentioned that for some of the data collection has had to shift during COVID and the way that this data is collected. But what's your sense in North Carolina about how, just access to care, that landscape has changed? for people who may be seeking treatment?
Yeah, that's an excellent question. And I will note here too in the chat, a couple of people have noted that their states have legalized marijuana and they still get reports for those infants with prenatal marijuana exposure to CPS. And so, there is sort of this balance of sort of thinking about the larger context surrounding marijuana use, what maybe the underlying drivers is some of that context. What does that indicate for infant safety and well-being outside of the marijuana use in and of itself? And so your question about COVID is a really good one. I know, we're doing another project across 13 different states where we're looking at changes and receipt of MOUD and specifically sort of new initiations of MOUD and initiations via telehealth during the COVID-19 pandemic in Medicaid populations. Have anecdotally heard that, some of the provisions in COVID, some of the changes around MOUD, so specifically allowing longer take-home doses, not requiring people to go to opioid treatment programs daily or even every couple of days for their methadone, have been really helpful in promoting treatment, that these initiations via telehealth have improved access to people who it may have really been hard to get physically to an office. So that's sort of specific to MOUD. In terms of these plans of safe care, I know, care management has had to move for a while to, care management via online interactions, which, our care managers in North Carolina with CMARC have indicated, it can be hard to get an assessment of what the home environment is like on sort of that, again, that larger context surrounding the infant prenatal substance exposure, and just harder to make a connection with families. In terms of CPS reports, in North Carolina, we've seen that they've gone down. It's really hard to know what's going on in the context of COVID. There are concerns that there have been increases in risks for child maltreatment, specifically related to the stressors of the pandemic, related to, increasing economic strain, unemployment, job loss among families. But children, also have largely been in their homes, maybe, haven't been seeing teachers, others who may have reported, suspicions of maltreatment to CPS. So I think it's, really hard to know exactly what happened there. I don't know if that fully answers your question, but I think, there's a lot of complicated stuff going on.
Absolutely. Yeah, thank you. Okay, more questions coming in. Carla asked a great question. If you could write the ideal policy around this, what would you have it say?
That's a really good question. I think the ideal policy, I think it would really focus on support rather than punishment. Infant safety is really important to consider, but I think, it would focus on, not all infants necessarily coming to the attention of Child Protective Services. It would sort of focus on more of that social service coordination, that care coordination, really that integrated treatment where substance use disorder treatment combined with the social services like the child care, the housing assistance, the employment assistance are sort of, integrated in a comprehensive way to sort of meet again, these co-occurring needs for infants and families. I think, all that research on these policies, child abuse, mandated reporting policies is indicating that these punitive policies are really deterring engagement in essential care and treatment, and that can undermine healthy outcomes. So how can we create more of a non-stigmatizing, non-punitive, recovery-oriented environment for pregnant and postpartum people? And so how to exactly operationalize that or fund that, I don't know, but I think, those pieces may be important to really promoting improved outcomes.
Wonderful, thanks. So Halia has a couple of questions. One is about what data we have on infants post-birth and their outcomes as they move into early learning, especially pertaining to how biological conditions may show up as challenging behaviors and how caregivers can support. I don't know if any of your research has been looking more at outcomes for children, or if you can point to any resources on that.
Yeah, there is, that's a really good question, sort of long-term, what do we see that these outcomes look like? I think there's, some mixed evidence, for some with opioid exposure, some indicate, an increased likelihood of learning challenges, some don't find that. I think, again, in these studies, it's really hard to disentangle the substance use in and of itself from some of the other co-occurring factors. So I think there's a lot of unmeasured confounding going on that really makes it hard to pinpoint sort of what is the factor that may be contributing to some of these results that we see in terms of later behavior or learning problems. So I don't have a good answer there. I think by and large, we're seeing that a lot of these infants do okay, particularly when parents are engaged in treatment and care early on in pregnancy, and are really supported in, addressing some of the additional challenges and barriers they may face.
Right. We're just going to rapid fire these questions because they keep coming in. But Terry Lewis asks, do you have any data on specific components of treatment programs for substance use that are associated with greater uptake, engagement, or completion of treatment for pregnant and or substance using caregivers?
Yeah, that's a great question. And so I think, from some of those qualitative studies I noted, those qualitative studies really indicate that there's increased engagement and uptake of services when pregnant and postpartum people with substance use feel like they're empowered. They feel like they're a key decision maker in their care. They feel like their opinions and perspectives are respected, that their healthcare provider communicates clearly with them. So again, sort of really these environments that are non-stigmatizing, non-punitive, really support continued engagement in care. I think also, some of the integrated treatment models, like I mentioned, that incorporate the social services piece, specifically, related to childcare or transportation, that break down some of those barriers to being able to access care in a continued way. Those have been shown to be really helpful too.
Great. Well, we just have a few minutes left. I wonder if you could share anything about your next steps for this line of work, where you see this work going in the coming years, and any closing thoughts that you want to leave us with.
Yeah, that's a great question. So I think, we're hoping to expand on that plan of safe care quality improvement project that we conducted in one county in North Carolina to be able to look at implementation across multiple counties, link together some additional data sources to see if there have been changes before and after, we started implementing that plan of safe care in terms of CPS involvement for substance affected infants and the level of CPS involvement, as well as, have there been changes in, pregnant people of substance affected infants receiving substance use disorder treatment, recommended postpartum visits, the child engaging in well-child visits, because in North Carolina, that's a big part of our program too, is sort of providing that care coordination and ensuring, infants and families are engaged in that. So that's sort of the immediate next step planned for this work. Always really excited for additional cross-state collaborations, particularly, and, thinking about how this legislation and these provisions have been implemented and interpreted differently across states. So if anybody is interested, would love to talk further, because I think, that will be a really important area to share sort of lessons learned, best practices across states as everyone's sort of figuring out how to comply with that capital legislation.
Wonderful. Thanks. Well, we're getting lots of thank yous in the chat. So I just want to say again, we really appreciate you coming and sharing this work with us. For everyone who attended, we'll send out the slides and the recording for today, so you can review those materials, and encourage you to register for next month's session. And thanks again, Dr. Austin, for being here today.
Yeah, thank you so much for having me, and thank you everyone for joining and your really great questions. I really appreciate it.
All right. Take care.
Thank you. Bye.